So good evening, welcome, and thanks. I'm glad you all came. And as a part of making things easier for you all to come and connect with us, we are doing this every month. My calendar is becoming more and more complicated, so I'm doing it every month so that you all can meet me, learn about a specific aspect of prostate cancer, sometimes about diagnosis, sometimes about how the biopsy is done, sometimes about talking about the genomics, sometimes who needs an MRI, what's the different ways of doing an MRI, sometimes talking about active surveillance, and sometimes talking about comparison between radical prostatectomy, radiation therapy. We did that just last one. Today's topic is very important because I will ask you a question. If everyone who has a prostate cancer in United States wants to live in one city, which city can accommodate them? Chicago. But the wives will not be allowed because there are 5 million people with prostate cancer and Chicago's population is 5 million. So if everyone wants to live in one, we will be in trouble. So basically, there are a lot of people who have been diagnosed with prostate cancer, and we have done a good job in treating the cancer so that people live for a long time. But that living for a long time is what we are going to talk about it, because this is one cancer which has an impact on sexual function and the urinary control part of it. And today, I want to focus on the sexual function side. Next month, we can talk about the urinary control part of the discussion. There are not many organs which are so complicated in terms of its location and how closely they are related to the nerve structures and other structures which have other roles to do it. It's deep inside the body. It was never meant to be kind of operated on easily. And there are certain ganglions, certain nerves, which are traveling, literally touching and hugging the prostate. So first part of this discussion, what I will do is to give you a basic feel about what the nerves are, how the prostate cancer is connected to the nerves, and how we are trying to save the nerves. Many times we succeed, many times we don't succeed. I'll give you my techniques, our understanding about it. But then there is a science evolving as to how to help in men getting the sexual function back by prehab, rehab, and other things. And these are two experts sitting. One is in the trenches, that is Joe, and Dr. Leon Telis is an expert only on the male sexuality and the sexual function discussion. So he will talk about what can be done, what we understand on this, practical aspects of it. So let me give you a feel as to what and why prostate cancer and the nerves are interconnected. So I want you to see this picture. This picture is of the male pelvis. This is the bladder. This is the prostate. This is the rectum. And there are many nerves which are traveling around the prostate. They look pretty simple here, but they are not that simple. And as a surgeon, I try to understand the anatomy myself. So this is my drawing: bladder, prostate, sphincter, rectum, and nerves are traveling around the prostate, and they are arising from the top of the body and from the spinal cord, the back. These green structures are the nerves, and these nerves are hiding in the layer of tissue around the prostate. So they are not exposed outside, they are hiding within the layers. And I want you to see this. These are a little bit graphic, but I think you guys can handle it. So this is a picture of a prostate, bladder. This is the major vessel, which is known as aorta. Aorta brings in blood from the heart, goes and divides into two parts. One goes to the right leg, one goes to the left leg. And there is in one part which goes and supplies to the rectum, bladder, prostate, and everything. So this is the abdominal aorta, this thing. And these yellow structures are the nerves, and these reddish structures are the nerves, and they travel around the prostate, and they kind of intermingle with that tissue inside. And think about it, underneath this is the cancer, and nerves are traveling in this area. And I'll make it simpler. In another patient, in another cadaver, we had an anatomy delineated. So these nerves are not just one nerve or two nerves. There is a plexus of nerve arranged around the prostate like in hammock, and they are hiding between the layers, and that is the concept I want to bring up. We came up with this idea that the nerves around the prostate are hiding between one layer, two layer, three layers, and these layers, if we understand, we can possibly choose the right layer to get into it, because sometimes cancer tends to escape outside. And I'll come on to that discussion in a little bit later. So this is the prostate from the side. There is in one layer which is covering the muscles. Nerves are underneath that. The blood vessels, the nerves are hiding, and there is another layer underneath that. That's the most of the veins which are there. And after that layer, there is a capsule, and inside the capsule is the cancer. And normally cancer is supposed to be inside the capsule, but 30% of the time cancer creeps out and goes outside the capsule. And that is the reason it becomes sometimes tricky as to when you can save the nerves, when you cannot save the nerves. But let's continue on this thought process. My team has been very much invested into understanding this thing in much more detail. So we have written books and chapters on this. But this is our own graphic design as to how prostate and the nerves are around that. So we have a very good understanding which side the nerves are coming, which layer they are going into it. And so this is the meshwork of the nerve, and these nerves are going down to the penis, and that's where the orgasm and erection part comes in. We kind of wrote some papers as to how we save the structures in a way that most of the nerves are saved, yet we get cancer out. We have called it as a hood technique, but I want you to see this. So what is happening, and this is the human body. We'll get inside the bladder. We'll get inside the prostate after that. Inside the prostate, there are millions of small cells, which we call glands. And one gland became abnormal. Those black cells are the one which are causing trouble. They are after growing, multiplying, till they reach a nerve, that's yellow structure, or till they reach a blood vessel. Up to this point, we are okay. What we call, this is an organ confined cancer. This is a cancer within the capsule. This is a cancer which has not gone out. And if I take the whole thing out, and if I buzz one of the part of it, there is a good chance that the story will be over and I can still save the nerve. But 30% of the time, this is what happens. This goes out and it goes through the nerve outside. And once it is outside, this is anyone's game, because now it is pushing on the capsule. It is using nerves to escape, and then it can go to the lymph nodes, it can go to the bone. So as a surgeon, as a doctor, we don't have to just know that the cancer can go. What is happening in that particular patient is what's important. And that's the reason we do a lot of testings, and I will come on to that discussion. One thing which we did not know till about a few years ago, early on, nerves are outside, and nerves are involved with the sexual function, and cancer is away from that within the prostate, all is well. But there is an emerging data in certain very high-risk cancers, like a Gleason 9 or a Gleason 10. Sometimes there is a cross-communication between nerves and the cancer cells, that the nerves will make cancer become more aggressive, and cancer will make nerve grow towards them. And when they come really close, cancer cells wrap around and go outside. So there is a collusion between the nerves and the cancer in certain number of patients. And we need to know where nerves are our friend and where nerves are no longer our friend. It's an important decision we have to make, because sometimes these same nerves, if we save them, will become the seedling for the next cancer, the prostate cancer coming back. So this realization was not there. We are writing a whole paper on that as to how nerves, they talk with the cancer and how cancer lures them It's a very complex anatomy. One of my fellows, Dr. Maheshwari is working on it. And very intriguing for us to know that how cancer cells convince known body's nerve to help them in becoming bad. But that's the reality and we are working on it. But 80-90% of the times, there are nerves which can be saved. There are nerves which can partially be saved. And there are nerves which are already cancerous. You can know that by all the testings which we do as an imaging, as an ultrasound, as an MRI, as in biopsy, as in rectal exam, as in PSA, as in biomarker, as a genomics, all combined, we can get a decent understanding of whether we are dealing with a cancer which is within the prostate, or is it going through the capsule, or has it already gone outside the capsule, is wrapping around the nerves? Is it wrapping around all the nerves, or is it wrapping around some of the nerves? That's the concept which, as a surgeon, I have to figure it out. Because if I am 100% sure that the patient has cancer only within the prostate, I'm more than 85% certain that I can save the sexual function. But if I'm iffy that there is a 15% chance that the cancer may be coming close to the head, it may be in the capsule, then I have to start thinking about, should I save it on one side? Should I save it a little bit on the right side versus give it a partial thickness? So all that anatomy which I was talking about becomes a useful tool for us. And before getting into the surgery, I sometimes sit down with the patient's own data. I will look at their MRIs, I look at their ultrasound, I will look at their exact view, I look at their biopsy, and then I can make a map in my mind. What am I dealing with in this patient? And what I'm dealing with in this patient on the left side versus right side, base versus apex, anterior versus back side. So we have to tailor procedures to that particular individual. And these are the thought processes which are going on in my mind. So I will do an MRI. I will kind of predict that this patient has some problem on the left side on the base. So I will tweak the surgery a little bit. And then at the time of surgery, I will wait for the pathologist to call me back and tell me that, you know what you took it out was enough. Or sometimes they will say that, you know what, left side on the base, you have taken enough out, but you may want to shave off a few more layers there. I have an opportunity, what we call a neurosafe at the time of surgery. This all goes on in each patient when we are talking about the nerve sparing. And we have put together a nomogram based on the MRI data, based on an exact view data, that we can have a better prediction as to who is a good candidate, who has some risk, who has a lot of risk. And off late, I have been really interested in looking at a micro ultrasound, which is an exact view. And that ultrasound tells me a lot about this white line. Can you see this thing? This is known as a prostatic capsule. This is all the prostate. This white line is the capsule. If I want you to comment, is this a good white line or is this a good white line? I think some of you can start appreciating that this part looks a little bit broken. Can you see it? That is where the cancer is eroding through the capsule. Was not picked up on an MRI, but this ultrasound started showing that this is fine. Here it is fine, here it is fine, here it is fine. But right where the urethra, where the base of the prostate is, this is the area where there is a possible extracapsular extension. We call it extracapsular extension. So all that combined, and this is where the line is that you can see things in a little bit more detail. So we are leveraging with the technology as much as we can to get that microscopic level detail, what is going on. So we have put together another nomogram using an ultrasound scan. And I'm just showing one case in which I'm pretty certain that the cancer has not gone out. And I can be very delicately teasing off the structures. And important thing for you to think about it, nerves are underneath this and the cancer is there. I can save that and there is a very good chance that patients will do well. But sometimes we deal with a situation in which cancer is aggressive and I'm about 28% worried that the cancer may be eroding on the right side through the some of the layers of the capsule. I know the anatomy that there are layer within the layer. I can find it what to do in that. Do we have no nerve sparing versus only nerve sparing, or can we do some partial thickness? That's what we call it incremental nerve sparing discussion. So we got lucky in our methods of doing it. I want you to see this video. This has been done in last few years. We started experimenting around with one cute technique, and let's see if you guys can appreciate. You are looking at the prostate. Prostate is on the right side, and this all is prostate. This is muscle here, and cancer will be inside. I have already gotten a feeling based on an MRI that there may be more cancer on the left side, and nerves are hiding in this area. So we started a new thing, which hopefully you will appreciate it. This is most atraumatic way of injecting certain fluid in the layer around the prostate. And as you know, rivers find their own way. They find the least resistance. Same way water finds its own least resistance. It finds the plane around the prostate. And something which is stuck will not move, but something which is loose will move, and nerves are loose. So if nerves are loose, they just move away from the prostate. And as you can see, same tissue, I can create layer within the layer, and until you will see the nerve. So instead of using mechanical instruments to dissect it out, I can dissect it out using this tool. And I want you to see that at the end, these are those hidden nerves. Leon, have you seen the nerves so cleanly? These are the nerves around the prostate, which we are able to dissect it out so that we can save it. And sometimes I can not only inject like that, the same ultrasound which I was doing it, I can inject that ultrasound at the time, and you can see this opening which is happening. It's because the nerves are being separated on the underside and the prostate is on the other side. And it's just that needle which is separating everything out. So we have developed certain methods of hydrodissection. Same thing happening here. And when we are injecting, this is how things swell up. If you are injecting inside, things separate out very delicately. And water is very delicate, so nerves, they kind of heal a little bit better. So what I told right now, that we got a very good understanding about the anatomy. We know how the nerves are around the prostate. We know that the nerves are hiding between the layer within the layer. We also understand, based on the Gleason score, based on how long it took for the patient to present, based on the pathological state, based on the PSA, 70% of the patients, cancer is within the prostate. But 30% of the time, different grades of it may be going out of the prostate. If it's going out of the prostate, we have certain methods because we understand the layer around the prostate, so we can stay in one layer versus second layer. That all is in very dedicated, very detailed surgical details, but we have developed MRIs, we have developed nomograms to predict it better. And at the time of surgery, we are developing very delicate and very atraumatic ways of dissecting these nerves out. And if someone has a perfect function before and patient has a really organ-confined cancer, you have a very good chance of regaining it back. If patient has a partial function or a patient has a partial spread around the prostate, that's a different discussion. And if, as I said, certain cancers have already joined the nerves and these nerves are no longer a friend, so we have to deal with them in a different way. Majority of issues happen at the time of surgery that we can do to fix this problem, but a lot happens before that and a lot happens after that. And that's the reason to talk about the rehab process, to talk about why healing happens, how healing happens. And I want Dr. Leon Telis to come and join the podium. But if someone has a small questions about my talk right now, I'm open for it.
What are signs of prostate cancer?
So this is one thing which is a silent killer. If you wait for the sign and symptoms of prostate cancer, maybe it's too late. So only way to really make a difference about prostate cancer diagnosis and finding the cancer when it is all within, that you go for a testing, just like we all were doing it outside.
How often?
Pardon?
How often?
Once a year if first PSA is normal. If first PSA is iffy, then little early, but someone will tell you exactly how often. This may be a good time for me to say what age. After 50 years of age to 69 years of age is a good time. If someone has a family history of prostate cancer, mom has breast cancer, someone has a pancreatic cancer, a couple of uncles had prostate cancer, they start at 45. Black men can start at 40 or 45 years of age because they have a higher risk of prostate cancer. But usually once a year is a good idea, unless and until something is not perfect in the first testing. Him and then you.
Hi. Quick question. If you compare surgery to radiation, what can cause more damage to the nerves?
I think at the end of 2 years, both can do the same damage to the nerve. If you get this kind of a separation, in which I'm very happy that the cancer is within, you have a 70-80% chance that your sexual function will be fine. But radiation changes happen over time, meaning radiation can damage the nerves. And you saw how close the nerves are. So radiation is not inside only, it comes from outside into. So at the end of 2 years, the sexual dysfunctions are pretty comparable between the two modalities. But if you really find a cancer early, you have a very good chance of healing out of removal.
In both options, radiation and surgery.
That's correct. Yeah. Please.
Instead of the external radiation as a possible scenario, can there be an embolization where actually go in where you opened it up and actually radiate it directly instead of the external machine?
Are you a scientist?
I'm a board certified pharmacy tech.
Reason I'm saying, I'm about to, before coming in, we were working on an IRB in which we are working on a study known as a Voyager study, in which we are using a radionucleotide small nanoparticles injected onto a particular zone of the prostate, working through the prostatic arteries and combining these two things together, hoping that we will directly deliver it to them and with having a lesser amount of side effect. There is another technology, I have been working on it. Not ready. It's not, don't ask for the offering. It's known as alpha particles. So there are particles which are beta particles or the protons and all those things, but alpha particle only go few millimeters around. So there is a company in Israel, I've been working on it. It's yet not ready in an FDA discussion here. So alpha dart is what we call him. So these are the different ways we are looking at it. We are trying to tag radionucleotides with the PSMA and do it before surgery so that these runaway cells, we can go and capture them. And then while I remove the 3 billion cells, those 500 cells which we're trying to hide out, we can send in PSMA tagged radionucleotide to go and get them. So a lot of developments are happening. Immunotherapies and different methods are being tried right now. But that was a good question. There was a question from the back.
You commented a little while ago that there's a correlation between breast cancer and prostate. How so? Why so? What's the correlation?
I'm standing in front of you. I am a sum total of about 50 plus trillion cells. And during holidays, maybe become 60 plus trillion cells. So that about certain number of my cells are going through overhaul. My skin cells, my prostate cells, my gut cells, they are changing. And when they change, that means they have to regenerate. So whenever there is a regeneration happening, there is a proofreading mechanism in which certain things read that the new cell which is coming out is all good or there is some defective. You go and buy fruits and you check it out which fruit is good and which doesn't look a little bit right. That checking part is known as DNA repair pathway. Every cell which divides has to go through a process of checking that your DNA, which is the new one, is okay. That DNA repair pathway is also known as a BRCA gene. So if the gene for the DNA repair pathway is a little bit sleepy or one or two livers are off, So certain cells go through the quality control and the Ford cart is made, and one with only 3 wheels and one with 4 wheels. So that is what, when it happens, that the breast cancer incidence goes up, prostate cancer incidence goes up, and these are known as the DNA repair pathway. And that's how more cancers they come up, because our body's control mechanism was little off.
Does the client's insurance makes a difference in terms of, could a client's?
I can read out that what he is saying. Does the client's, meaning the patient's insurance, makes a difference in terms of what treatment they got? Is that what you're saying? I mean, I think the fact that someone can see a doctor is driven or controlled by the many layers of these bureaucracy. So insurance does makes a difference as to who can come. But this mobile unit, which you are seeing outside, is insurance irrespective. You have seen that blue unit, which is outside the team who's testing it. That's the reason we have done it. So that discussion doesn't apply in this part of our team. So let's not talk about all cancers. Let's focus on prostate. So we don't have a magic this versus that discussion, but we do know people who were exposed to cadmium, people who were exposed to Agent Orange, people who were part of the ground zero exposures, they had more cancer. So inflammation is not good for the cancer. Chemical exposure is not good for cancer. Too much of animal fat may not be good for cancer. Too much of red meat may not be good for cancer. Too much of sugar may not be good for cancer. People who don't eat enough vegetables, the greens, may not be good for cancer. Inflammation, I'm saying it second time, inflammation coming from any which way is a known predictor of cancer. So managing inflammation, sleeping, exercising, keeping the weight right, remaining sexually active, all those things are important part for the prevention. People did try to have a trial in which medications were given. I'm not a pro for medications. People were trying to do selenium, it didn't work. But eating normal supplements, exercising, sweating it out, eating good greens, and being balanced, I think that's your best, and getting checked, please.
My question is about diagnosis. So it's about a man who presented at 47 with a PSA of 16, asymptomatic. A few years later, had developed lower urinary tract symptoms, had a TERP, still negative biopsy. CT scan only showed a large prostate. 20 years later, the PSA is still at 8. What's going on there? Is it prostate cancer undiagnosed? Is it likely to become prostate cancer? What does one do with that high PSA after so many years?
Why PSA is high? That's an important understanding for us. PSA is produced by the normal prostate cell. PSA is produced by cancer prostate cell. PSA is more produced by inflamed cell. People can have a prostate of 20 gram. I see every now and then 200 gram prostates. So the fact that the big prostate is there, it will produce big PSA. As long as there is no discriminately higher number of cancer cells in there. So if someone who started at 46, 20 years later is still going on, so that means that person is about 66 right now. And has had a TUR, has had a biopsies. I think the PSMA PET scan is a good idea. Doing a genomic test known as confirm MDX from the negative biopsy is a good idea. Getting a test known as a 4K or an EXO in the urine is a good idea. Getting an exam, ultrasound, and those things are a good idea. And keeping a close eye on it. So your final question was that are we missing a cancer? I mean, 10% of the times, even with a normal MRI, you can have a cancer. We call it stealth tumor. But the fact that you are being followed very closely, unlikely. But can it change into the cancer? Yes, it can. So don't lower your guards.
Just a quick follow-up on that. If it's 20 years and the PSA is not progressing, if you do find cancer, do you treat it?
So prostate is in one cancer which carries the name cancer, but 20 different people will have a 20 different kind of a cancer. One will have a house cat, another will have a tiger, someone will have a coyote. And you need to know what you're dealing with. So finding what it is a good starting point, but not everyone needs an intervention. But you need to kind of label what we are doing. Mike, can I give 2 more?
If the prostate is gone, What are they attached to?
So the bladder goes and fills in the difference between the urethra and the prostate. And those tissue which we have separated it out, they form their coating around. So they are lying on a pillow of the normal tissue which is out there.
Can you say anything about cryotherapy? Is that promising in any way?
So I think this question is driven towards, do we need to take the whole prostate as a treatment option, or can we do a part of the prostate? If you are pretty certain that it's only one side of your prostate which has a cancer, and it is not Gleason 7, 4 plus 3, it's not Gleason 8, it's not Gleason 9, it's a little bit of a 7, 3 plus 4 kind, you have options, what we call focal therapy. And focal therapy, one of the forms, so focal therapy is that you want to kill something with the least disruption so that things don't spread outside. And you can kill it by electrical current. You can do it by freezing, by ice crystals. You can do it by heating HIFU. You can do it by immunotherapy or chemicals. There are different combination of things. I must say that there are a couple of very good guys about cryotherapy in New York and a couple in New York. So it's an option, but just in a very deliberate manner, you have to choose. You look a little young, so be careful.
Do nerves grow back? Small ones, large ones, which got cut or destroyed? Do they have a chance to grow back again, or once they are gone, they're gone?
So I have seen people getting better even at 3 years. So I think there is a little bit of a nerve regeneration which happens. We have even a clinical trial happening in which we are trying to connect the nerves to the certain different kinds of nerves. So simple answer is, yes, it's possible. Complicated, it is very small. So nerve regeneration, people have tried the shockwave therapies and medications and all. So a little bit of regeneration. Maybe you will touch upon this more. Go ahead, please. Yeah.
Oh, okay. My understanding is to confirm a diagnosis of a prostate cancer, you have to get a biopsy, correct? And the analysis of a biopsy would determine and confirm whether you have cancer or not, for the most part, correct? So, and you said that in general, you should be getting your PSAs and staying on top of a senior urologist and making sure that everything is okay. So if the scenario is you have a 69, 70-year-old person, let's say, that has good PSA numbers. In fact, the trend is that they're decreasing. But you have other classic symptoms that may suggest that something else is going on within the prostate, other than enlarging prostate, because I mean, PSAs are going lower and lower and lower. In fact, there are trends where the most current one was lower than the fourth one back in the trend. But still, you have these urgencies and you have frequent urinations and you have all kinds of things like that that suggest something is going on in that area. Should I be concerned about possibly cancer as well, even though the numbers in the PSA numbers are not indicating that there's a problem?
PSA is not perfect. And if there is by the way, the symptoms and features which you are mentioning most likely are because of inflammatory process. But don't lower your guards. There are other ways. What does the MRI show?
Everything is fine. My urologist doesn't.
Fine is not fine.
Yeah, doesn't think that there's a concern for me because of other things. But
so inflammation itself.
But I do heard you say that you don't want to wait until and find out later
come
when
back
it's too
next
late for
year,
the cancer to be diagnosed.
Come back next year because inflammation predisposes for the cancer down the road. So all these features which you're talking about, it could be chronic prostatitis. Fine, they need to be tackled. Could be an imbalance of the muscles of the prostatic area that needs to be tackled. But your risk of prostate cancer hasn't gone down. So you still have to keep an eye on it. If someone is 80 years old, that's a different discussion. But if someone is otherwise having a good life expectancy ahead of them, the PSA, let that be handled by someone. And now there are tests. XO is there, 4K is there. MRI, I think is an important test if someone's PSA is still high. So all combined, you have to look at the perspective. Everyone has their own PSA profile, and a good doctor keeps an eye on that profile rather than one absolute number. I have seen people's PSA going down and is still finding cancer.
That's the real question that I'm trying to get at. So it is possible.
It's possible, but don't get scared. You're doing everything fine.
Okay.
But just don't lower your guard next year.
Okay.
That's what I'm saying. Come on over. And I'll be again back, and then I'm not going.
Okay, so thank you all for coming. I think that was an excellent intro into discussing what we can then do for recovery of your life and your erectile function after prostate cancer treatment. So I'm going to go into a little bit of background first. As we all know, prostate cancer is extremely common, and Dr. Tewari mentioned up to 5 million men in the US today. The treatment options between surgery and radiation both can cause erectile dysfunction. A lot of it is a matter of when are you dealing with it? Are you dealing with it initially up front with surgery and waiting for some recovery and the erections improve up to 2 years, up to 3 years out? Or in the case of radiation, are you having minimal side effects initially with some of these things developing down the line? Erectile dysfunction is extremely common, not just in patients, obviously, that are undergoing prostate cancer treatment, but it affects about 1 in 5 American men 20 years or older. And men, more than half of men over the age of 40 have some degree of ED. There's a number of different causes of erectile dysfunction. There's vascular, neurogenic, something that Dr. Tewari had touched upon, hormonal, psychogenic, meaning, is anxiety a component to this? And the top 3 physical causes in general, things that have that affect vascular conditions. So we often say that one of the earliest signs of heart disease is the onset of erectile dysfunction in an otherwise seemingly healthy man. Physical causes. And these are often in combination. So as far as some background on prostate cancer and post-prostatectomy erectile dysfunction, about 28% of men have no erectile problems 5 years post-prostatectomy without an aid. And that aid could be things like medications or injection therapy that we'll talk upon. And an additional 45% of men will report significant improvement with a PDE5 inhibitor. So those are drugs that we're all aware of, like Viagra, Cialis, Levitra, et cetera. And some men are continuing to improve late if their nerves are spared. And as we all also have to keep in mind, all men are aging. So even if nerves are spared, but as time goes on, and a man that didn't even have his prostate removed, we will all develop some degree of ED down the line. As far as causes when it comes to treatment, so about those categories that I discussed, the vascular and neurogenic and hormonal. So vascular causes for ED will happen with both radiation therapy or with surgery, but it is more likely with radiation therapy. Neurogenic causes, so things that are affecting the nerves, occur with both radiation or prostatectomy, and in this case, it is more likely with prostatectomy. And hormonal, so hypogonadism or low testosterone in prostate cancer patients can be treated, and I'll touch upon that a little bit down the line. But it traditionally years ago was thought that giving testosterone supplementation to a man that was treated for prostate cancer is crazy, but we now know it is very much safe to do as long as you're being monitored appropriately, and especially depending on the type of prostate cancer. So patients who have, for instance, high-risk prostate cancer are treated with androgen deprivation therapy. Additionally, we would not recommend doing that, of course, but in appropriately selected men, it's very much safe to do so. And I'll talk about that later as well. And psychogenic causes, of course, the cancer is a diagnosis that affects us mentally as much as physically, and that will also have an effect on our erections. So what are some predictors of erectile function recovery after radical prostatectomy? How can we predict who will have a better outcome than others? So things like age, preoperative erectile function. So I always tell people that a radical prostatectomy or radiation therapy or treatment on the prostate of any kind has not ever helped anybody get an erection. So what we can hope for is recovery to the point of your preoperative function. And that's what we hope to get to recover that baseline preoperative erectile function. And somebody that's already having poor erections pre-op, I was telling them, you're not going to miraculously have a 10 out of 10 erection afterwards. Nerve sparing, so something that Dr. Tewari had spoken about. Cardiovascular risk factors, so cardiac disease. And of course, surgeon volume, how experienced is the surgeon that is performing your operation? And salvage treatment, are you requiring any kind of additional treatments like radiation after surgery or hormonal treatments afterwards? This is a chart here from a study that was published in 2009 that really one thing I wanted to emphasize here is the importance of starting penile rehab, which is something that we always encourage patients. And something that is a good prognostic factor is starting penile rehab quickly or prehab, even prior to surgery. So rehabilitation that starts over 6 months after prostatectomy has less of an effect in improving erections down the line. ED from prostate cancer treatment. I'm not going to go too much into this because Dr. Tewari had discussed this and he had much better pictures than I do. But as we see, the nerves that are surrounding the prostate are peeled away carefully, hopefully, and then the prostate is then, the urethra is then reattached to the bladder and the nerves are left to the side. So the mechanism of post-prostatectomy erectile dysfunction, there's a lot of little diagrams here, but all of it comes down to this thing in the center, what's called cavernous hypoxia, meaning oxygenation of the tissue within the penis. And during surgery, there have been shown, actually, a study that I know Dr. Tewari published when we're still at Cornell about monitoring oxygenation during prostate cancer surgery and trying to use various techniques to maximize the amount of oxygen that the penis is receiving in order to preserve erectile function, I should say. And whether it's vascular disease or whether it's neurologic disease, all of it comes down to the amount of blood flow that the penis receives. This is a study that was done that shows some histologic, meaning done under microscopes, changes in cavernous tissue after radical prostatectomy. The cavernous tissue is the tissue that in the chambers of the penis that fill with blood for erection. So on the left side, you can see these are patients with normal erectile function, and then patients that are 2 months post-radical prostatectomy. These are biopsies of that tissue that show an increased amount of collagen to smooth muscle. And that's because the theory is that is due to the amount of oxygen that's being supplied. So as you lose some oxygenation there, you have increased deposition of collagen, which is a connective tissue that does not allow for blood filling. This was a study on animal models, actually, that looked at the effect of chronic tadalafil, which is Cialis administration, on penile hypoxia, which just means a lack of blood flow, lack of oxygenation, induced by something called cavernous neurotomy. Basically, they were cutting the nerves that were supplying this area. And if you look here, the staining, basically on A in the top left corner here, shows how much oxygenated tissue there is. And when there is no oxygenation, you'll see some changes there that are primarily an increase in collagen deposition. And then in C on the bottom left here, this was an animal model that received chronic tadalafil. So this was the medication Cialis that helps to improve blood flow to the penis and improves oxygenation. And it preserves some of that architecture that you can see on the upper left as well. So what are some treatment options? I want to touch briefly on a couple of things that are very popular out there in the media and that are being advertised and people will often come in with questions about. And these are things that the American Urological Association reports that should be considered investigational. There's not a whole lot of evidence that they will help. And I will also add that most of the time they will not harm things, but as far as kind of improvement, I will never tell people that this is definitely going to make you go from 0 erections to 100. And those are things like shockwave therapy, intracavernosal stem cell therapy, and platelet-rich plasma injections, or PRP or P shots as they're often called. These are things that have been trialed, and there have been a lot of studies that have been fairly inconclusive. It is, I think, in some cases worth trying in people who are interested in them. But I always kind of try to set expectations as to the results on them. We'll touch upon all of these various options: oral medications, injections, vacuum erection devices, urethral suppositories, and penile implants. These are all valid options. So penile rehab was first described back in the late 90s. And the idea was to use early on intracavernosal injections, so shots that will induce an erection post-prostatectomy. And the idea behind that is that if you induce an erection, that will draw in oxygenated healthy blood flow and preserve that tissue in the penis that's responsible for erections. And then following that, use of oral PDE5 inhibitors, so those medications like Viagra and Cialis post-prostatectomy. Penile rehab has kind of evolved over time and has grown to include assessments of all sorts of different aids, including vacuum erection devices, intraurethral suppositories, intraurethral gels, in addition to injections and medication. It's utilized commonly, even though there's actually not a whole lot of consensus in terms of the protocol that exactly should be used, and sometimes in terms of the benefit, but it definitely has been shown to help people. So as far as what we do, we evaluate patients preoperatively. We'll often recommend patients start some kind of oral PDE5 inhibitor, whether it's Viagra or Cialis, especially if they have never tried them before, and to start that before surgery. And there's a number of different protocols that are recommended, but after catheter removal, we recommend either nightly or every other night dosing of some of these medications. We also will discuss vacuum erection devices and injections as options at each visit. Oftentimes will depend on how much the patient's willing to do or would like to do and how motivated you are. Oftentimes now we'll even recommend an injection of some of this medication at the time of catheter removal in order to bring some of that blood flow into the penis. So the goals are, they're simple. They're early return of function, regular oxygenation of penile smooth muscle. And some of the factors to keep in mind are cost or insurance coverage, how easy is it to use, what's the burden psychologically on patients, and are there any harmful effects on it as well? And that's something that is always discussed on a case-by-case basis. Other issues after this surgery for prostate cancer include things like peyronie's or curvature of the penis, loss of, there's always a discussion of testosterone replacement after prostate cancer treatment. And well, one other thing that I don't have on here, but it's also talking about expectations in terms of orgasmic function and ejaculation. And, you know, sometimes I'll see people that were treated elsewhere that come and they were not even aware that they'll have a dry ejaculate post-surgery. They'll still have a sensation of orgasm, but you won't see anything come out. So I'm not going to go through this entire slides, but this is really just, I just put this all up here to show just how many trials have been done in terms of trying to figure out the benefit and protocols for penile rehab and what medication to use, what dosage to use it, what frequency to use it. And bottom line, the kind of take home point that I want to point out here is really primarily that there is improved erectile function with a variety of these different treatment options, even though it hasn't been fully standardized. So I'm going to actually turn over to Joe a little bit here to talk about some oral medication options, some injection options, and then I'll finish off with a couple of slides as well.
Okay, I'm the guy you see usually after surgery. I'm the one who does all these procedures with you and stuff like that, either the injections, the gels, the shockwave therapies. We adjust your oral intake of either PDE5s. You know, we have the, you know, any improved blood flow is going to help heal your tissue, and hopefully the stimulation help with your nerves. Like some of the common side effects when you're taking the pills, and some people, they bother too much. They have a headache or stuffy nose, you know, like Viagra, I can't personally touch because I'll like lose my breath. The ICI, the intracavernosal injection, you have two big arteries in your penis, and they're called your corpus cavernosum. When you inject the medication in, they're vasodilators. We have a few different kinds, bimix, trimix, quadmix. They're just different combinations of medications. So it works really well for the most percentage of men, you know, and we want to get you a nice rigid erection, you know, one to stimulate your tissue and nerves, as well as for intercourse or masturbation. The side effects of it, you know, it's a needle. It's a tiny little needle. It really doesn't hurt. 90% of the men say they're freaked out about it up front. Okay, but once they have it, they're like, oh, that was it. Also with the needles, you never want to keep hitting the same spot because you don't want to develop scar tissue. Okay, if you don't inject the needle far enough, you're going to get a bruise. All right, and you can always get a bruise no matter what. Reasons people stop it, you know, sometimes it doesn't work as well, and so but we have stronger medications that we can go to, and a lot of times it's an injection technique. The vacuum erection devices, they're really easy to use. Basically, it's a tube that sucks air into it. It'll help with bringing the oxygen to your penis. You know, it's a different option, but you can use it in combination too. Okay, especially with the pills. You know, you use it and something called, for layman's term, a cock ring. You know, where it actually occludes the blood from running out. So you pull it in with the vacuum device and include it, and this can help with your rehab as well. After prostatectomy, you're not really going to have to worry about the blocked ejaculation. But a lot of times you you don't want to pump it too hard because it's going to become painful. You can get bruising, and also it can just suck up the it'll hurt. You just get it rigid enough to where your penis was before, and then you can have more normal sex life, and hopefully with the combination you'll start to get it back on your own. Yeah, just like any one of the other ones, pain, discomfort, and it doesn't work as well for you. A lot of people, that's usually because you have to shave a lot of times so you get a good seal when you're vacuuming, and people don't want to do it and stuff, so it doesn't work as well. Urethral suppository. This is something called Muse. It's like a little pill that goes up your urethra. We don't use it as much as often because they've developed new things called gels, intraurethral gels, which are much easier to use. Most men like to try these first because there's no needle involved. They work very well, but everyone absorbs medication differently. So sometimes they don't absorb as well, and the injection would work better because you get the medication right into where you need it. People like to try it first, again, because no needles. There's always a cost-benefit ratio. These come from pharmacies, and the gels are always more expensive, but a lot easier to use. No pain from the needle, okay? But some people, it can burn when you urinate. But you don't know till you try it, but the majority of people do very well with them. People do better with the injection, but a lot of people do very well with the gels, and that way they don't have to go through the injection. So, this is going to come back to you. Okay, all right. Okay, that's my part. Thank you.
Is the gel available in the US? And how costly is it in the US?
Okay, the pharmacy we get it from now, it's $25 a syringe.
And that lasts for how long?
It's single use.
$25 for each one.
Yeah, single use, yeah. Mm-hmm.
And is
So
it a
there could
brand
be
name or is
there
it
can always
compounded?
be affordability factor.
Is it a brand name?
Huh?
Is it a brand name gel?
No, not at all. We have to get these from compounding pharmacies.
That's what I thought. Okay.
So they're custom made. And we have different ones that do either a single gel, a single medication, phentolamine, or they'll do combination therapies. But when you go to like a trimix therapy where they add a third medication called alprostadil, it can cause a little pain. Okay, in less than 15% of men though. Okay, we always have to look for that as well.
I got the Trimix from Americare Compound Pharmacy in Garden City, and it came out to about $82 for a vial, which they said should last about 15 or so injections.
Yeah, it depends on the amount of volume you use in each time, and but
it was 0.3 mil.
Yeah,
0.
units. Yeah, you're
0.03
using units. Okay,
yeah.
yeah. It's just small. It usually only comes in a 5 milliliter vial.
Yeah.
But and that's actually a good price for it because a few other ones are a little more expensive at 120, 130 a bottle. Mm-hmm. You know, that's why we use the different pharmacies. But like Americare with the Viagra, they still charge $65 for 90 pills. But so we send it elsewhere.
So thank you all for the presentation. It's very informative. General comment, I'm a housing organizer. And with respect to insurance, it's profit. It's about capitalism. Whole different topic, man. You got to take it away, right? It's big business. But the question I have, I'm a 67-year-old African-American male, 2 uncles on my mom's side of the family that died from prostate cancer. I was going every 6 months to be tested. I used to go to 10 Union Square East, see Dr. Gulliver. He sort of retired or went in a different direction. The pandemic comes and I stopped going. So I recently bugged my primary care physician to check my PSA. It's a little bit elevated, so I'm going to get back into a routine. But the question I have is, over a historical time frame, how much does a normal X-ray possibly affect the prostate? Let me tell you why. I've had 17 orthopedic surgeries in my lifetime, right? And most of them, 15 of those on my right hip, which means I was constantly getting X-rayed going back to the 70s. X-rays haven't changed too much, right? The person who takes the X-ray, you know, sets you up and then they run behind a shield, but I'm still exposed. So the question is, over a period of time, and maybe Dr. Tewari, you want to respond to that, or if you could, I mean, I'll take the answer from anybody. Will that have a long-term effect?
X-ray as such is not very good beyond a certain number. but your family history is more troubling than your X-ray exposure. So, but do also check not just the prostate, you should also check your bladder. You don't smoke.
No.
Because bladder also comes into the same zone. So as long as you catch up, and by the way, you should have caught up today. Outside, you could have gotten the PA. Yeah, but do the PSAs, do a urine test to rule out anything else. But your family history is more bigger a driver than just the exposure of radiation. Radiation does other things, but not directly linked to the prostate so far.
Do statins affect the ability for these drugs to work?
Statins.
Statins.
Not a significant amount.
Okay, thank you.
It's a good idea to take it because it can keep your blood vessels more pliable, anti-inflammatory. So if it anything, it may help.
Increasing testosterone artificially, is there a link between that increasing testosterone artificially and cancer? Is there a relationship between that?
So this has been a study of a point of debate for a fairly long time. And at this point, you're talking about in patients that do not have prostate cancer diagnosed or somebody that's had
And
prostate
they
cancer?
don't have prostate.
Yeah, so there is no evidence to demonstrate that taking testosterone replacement therapy would increase your prostate cancer risk. In fact, there's been a number of studies that have shown that patients who have low testosterone levels for a significant period of time were actually found to have higher grade prostate cancer at time of diagnosis or treatment.
So what you're saying is it's probably safe to increase testosterone.
Any hormone in our body gets regulated by our pituitary and hypothalamus brain and different glands in the body, though there is a very fine balance. So unless and until someone who understands that balance is the one supervising you, that may be a trouble, because very high testosterone level, which is what is your very high perception, I think it needs to be managed by someone of his caliber. So don't just shoot something because you can have an access to it because you're not seeing the report. People did worry about it, and definitely after prostate cancer, many a times we are little paused, cautious if it's a Gleason 9 high decipher and those kind of a things, so T3A or rising PSA. I do start on after surgery or after treatment, but in supervision because someone needs to monitor it very closely.
So we'll finish up this presentation quickly. I have a few slides to just go through about penile prosthesis surgery as our kind of last and final option here. So historically, penile prostheses have been around for quite a while. They were first developed in 1973 as a 3-piece device. At that time, they weren't working very well. They failed as high as 45% of the time. They had very high infection rates. About 1 in 4 of them would get infected. But they've come a long way since. And there's a few different kinds of these devices. There's the most commonly used 3-piece inflatable penile implant, or the pump as people know it, 2-piece inflatable devices, and malleable penile implants. And we could talk about all of them. But people are generally quite satisfied with them. The kind of downside of it is, of course, it is a surgery, and it's a surgery that you have to recover from. People are satisfied in terms of sensation, in terms of orgasm. This really just takes the place of the actual mechanical aspect of the erection. They are typically covered by insurance and or Medicare completely. They're permanent and concealed, and they're quite durable. They have an average lifespan of about 10 years. Some people, it lasts significantly longer. Some people, it's shorter. But they are designed to maintain a natural appearance, and they do not interfere with ejaculation or orgasm. There are, of course, risks to the procedure. They may be associated with a mechanical failure at some point. If the prosthesis were to stop working, then it is a revision surgery to fix it. It does make natural or spontaneous erections impossible at that point. So you can go from medications or injections to implants, but you can't go from implant back to any of those other options. And then there is the thing that we always speak about the most, although it's quite rare, about a 1 or 2% chance of an infection of penile prosthesis. And although that sounds low, it is a significant thing just because since it is a foreign body, if that were to happen, the device has to get removed, and it's several months until you can get a new one placed. So it is obviously a devastating side effect. And then men with uncontrolled diabetes or spinal cord injuries or other various infections do have a slightly increased risk of those infections. Just have a quick video on how these work. Just put for a few seconds here. So the pump that's placed in the scrotum almost feels like a third testicle. There's two cylinders that replace those erectile chambers of the penis that fill with fluid from this reservoir that's placed in the pelvis. And when you'd like an erection, you just pump it up, it inflates. And then when you push a button, it deflates and you have a penis that looks like a normal flaccid penis. So it is generally performed as an outpatient procedure under anesthesia. You go home the same day. It's about a 1 or 2 inch incision in the scrotum or above the pubic bone. And you're basically back on your feet within a week or so. And I usually tell patients it's about 6 weeks until you can actually start using the thing. And then, so that's it. That's about penile prostheses. We did sort of touch upon this also, but hormonal treatment after prostate cancer, this is the thing I kind of wanted to finish off with. It has been controversial for a number of years, but it is much less so now. And there's been a lot of studies that have been shown that it is safe in appropriate patients. And there's been most studies that have been done in patients with low or intermediate risk prostate cancer that we know it is safe to give TRT when necessary. That's essentially what we have for the presentation. If we have for questions.
Thanks again for coming and give us some ideas as to what next topic we can talk about. Continence seems to be one of them. Active surveillance seems to be one of them. But still, if someone has a question for me personally, can come back and then I'm here. This meeting has started so that you all have an access one-on-one with me, just in case you need to. Thank you.